the limit of blank, limit of detection, and limit of quantitation. So if you see here, the limit of blank is lower than limit of detection and then the limit of quantitation. So these three terminologies you will observe in all new next generation essays, because this is the minimum requirement for the quality standards guideline from the CLSI. So I have a one important slide I will share with you soon, and then the linear range. So you can see that usually the linearity, lower linearity is based on a limit of quantitation, or in some cases the labs are using limit of detection as a limit of as a low linearity. But the difference between the limit of detection and quantitation is the coefficient of variation. So the limit of detection, which is the lowest detection value with the coefficient of variation, is higher as compared to the limit of quantitation. So let's start with some information which is related to the limit of blank, limit of detection, and limit of quantitation. So let me share with you one slide which is very much informative. So if we talk about the sensitivity, so according to the CLSI guidelines, that's the CLSI EP 17-A, that's the major basic point for the understanding of the limit of the measurement. So what is the limit of the measurement? One is called LOB, LOD, and LOQ. So what is LOB, LOD, and LOQ? If you see that this is a relative frequency and then the limit of blank. So what is LOB, or limit of blank? This is basically a highest results expected for a blank samples. This is also referred as a white noise. As we know that, the electronic systems have some noises. So if you have nothing in the solution, their signals, this instrument, due to the electronics, they have creating some signals. So the highest results for the blank samples is known as limit of blanks. So if you go back to this slide, so limit of blank is basically a value of blank sample with the highest value. That's basically a noise for that blank sample. Okay. So if we go back to again, another concept, which is limit of detection. If the lowest concentration of analyte that consistently detected in greater than 95 percentile of the sample is called the limit of detection, right? And the difference between the limit of detection and limit of quantitation, both have a lowest concentration of analyte, or a lowest analyte concentration, which can be measured at a set precision and bias. What is the set precision and a bias? Basically, this is a set precision and bias of lowest analyte according to the CLSI guidelines. So if the lowest analyte
он и доработал бы, например, там, до следующей недели. И, блин, у меня на следующей неделе не будет. Тогда уже там сами будет. Блядь, да надо было уезжать.
Okay, Melia, you asked that, please tell me, will we have a technical part of the training using the
Блядь,
analyzer
да, а что потом будем делать? Ну, хоть как-то он будет держаться, а то вообще не будет.
Milia, I have no idea about your technical part of the training with the analyzer itself. You need to contact your Chinese manager in Russia. They will guide you. They will give you the training plan for the technical part of that, right? So I am just responsible for today's session. I have also shared with you the link for the training feedback. If you want again, then I can make a copy and print it here, right? So this is the link for the training feedback, because today is my day 2 and the last day for the training, and I'm responsible for the tumor marker and total PSA and free PSA assay
Нихуя не
training,
будет, а?
application training for you. And I have no idea about your instrument training. You have to contact your Chinese colleague in Russia. Thank you. So here you can have a clear concept about the limit of blank, limit of detection, and limit of quantitation. So the blank is a blank sample, but due to some noise, electronic noise, it gives you the some concentration. But actually, there is a zero value of target analyte in that sample. And this is the highest result that they have observed for that sample. The second thing is the limit of detection and limit of quantitation. They both have a lowest concentration, but only the difference is that the limit of quantitation major value has a set precision and the bias, while the limit of detection, they have a more than 95% of the samples detect consistently that value, but their precision or the coefficient of variation is higher than the guidelines which are recommended by the CLSI. Okay. So I hope I cleared the concept of limit of blank, limit of detection, and limit of quantitation. So in some cases, when you have, for example, the limit of blank is 0.4. So the limit of detection is 0.6, and the limit of quantitation is 0.8. So in this such cases, the linearity or the linearity of the assay for the lowest detection limit and the highest detection limit is based on the LOQ. Usually the labs use the LOQ, but in some cases they use LOD as a lower linearity of assay. But usually they prefer to have a LOQ because the LOQ major value have a set precision and bias. And I hope I have cleared your concept according to the CLSI EP 17-A guideline for the limit of blank, limit of detection, and limit of quantitation. Is it clear, concept clear about LOB, LOD, and LOQ? So that's great. Thank you. Let's go back to the original presentation. So if you talk about cancer antigen 24-2, so the CA24-2 found in the same mucin complex, that is CA50, and ciliated Lewis, that's the CA19-9, and may be used to screen the colon cancers, pancreatic cancers, and lung cancers. In a normal cell, these are the proteins which are released during the birth diagnosis, while in the cancer cells, these biomarker, this is CA24-2 as in pancreatic cancer is released, and it is in a higher specificity than CA19-9, and it's only detection for the pancreatic cancers and differential diagnosis between the pancreatic cancers and pancreatic benign disease as well. So the joint detection of CA24-2 and the CEA is used to diagnose the curative effect monitoring of the colon cancers. So according to the International Journals of the Clinical and Experimental Medicine, the tumor markers like CA19-9, CA24-2, and CEA is the diagnosis for the diagnostic tool for the pancreatic cancers and or a metastasis analysis. So overall, according to this publication of International Journal of Clinical and Experimental Medicine, its conclusion is that if our meta-analysis showed that CA24-2 and 19-9, they have a better performance in the diagnosis of pancreatic cancers than CEA. Furthermore, the parallel combination test of 19-9 plus 242 could be a better diagnostic value than the individual 24-2 and 19-9 test. So if we talk about the pancreatic cancers specification, we have to compare the CA24-2 first generation with the second generation. We have a sandwich principle. The principle is same. The calibration interval is improved from 7 days to 28 days, which shows that a more reliability of the onboard reagent stability and the sample volume is equally good as compared to this first generation. We have an improved serum and plasma type along with the same reagent pack size of minimum 50 and 100 pack size, and the LOB, LOD, and LOQ is improved. You can see here that we have an LOB is 0.7 to 0.5 to 0.7, and the LOQ is 0.8. And before that, they have only used the limit of detection before that, and now they are using LOQ for the low linearity of the assay. So they have improved the assay linearity. Improve was in the first generation, but according to following the CLSI and the quality guidelines for the linearity verification and then process, they have provide a quality standard linear range for that. If we talk about the diluent including, they have 1:10 dilution on board stability with the 2 level of free of cost QCs are available along with that. And that's then about the whole assays availability with that. So if we talk about the liver cancers, so in liver cancers, it's also known as hepatic cancers and the primary hepatic cancers, and then it's start in the livers. So cancer which is spread either to the liver is known as liver metastasis, and that's the more common that start in the liver. So the leading cause of the liver cirrhosis as of today is hepatitis B. And there was an interesting thing that I have observed in China during my visit. They have a more prevalence of hepatitis B as compared to the hepatitis C. And I was surprised to see that. Do you have any idea what is the reason? Because even the hepatitis B has a vaccine is available in the market, but the C, as of today, there is no vaccine. Only the cure prevention is available for the hepatitis C. But the prevalence of hepatitis B in some countries is more as compared to the hepatitis C. Do you have any idea about what is the reason for this virus infection as compared to the B, as compared to the C virus? And the both leads to the cirrhosis of the liver. So any idea about that? Okay, let me share with you. There is a big challenge of mutants. Even in some countries globally, they are developed countries or maybe a developing countries. They have a vaccination program. They have a fully vaccination, but it's still due to some genetic mutation in hepatitis B, the prevalence of hepatitis B is more as compared to the C. So that's the reason the vaccines are not effective against that mutants which are present in that specific countries. So for the leading cause of liver cirrhosis, either through the hepatitis B, C, and the third risk factor is alcoholism. So the most common type of the hepatocellular carcinoma, which makes around the 80% of the cases, are the cholangiocarcinoma, and the last common type, which is the mucinocystic neoplasmic and intraductal papillary biliary neoplasmic. So if we talk about the global distribution of liver cirrhosis, it is estimated according to the WHO guidelines for the international agencies for the research on cancer 2018 data. As per the world, per 100,000, 8.4% people have died due to this liver cirrhosis or the diagnosis. The more regions in this areas are here. The China, the most probability the presence in the Russian region, and then there's some in Middle East countries, and in the even in they have more prevalence in the North American countries. So including the Canada, USA, and the other countries which has some Mexico and other countries. So if we talk about the alpha-fetoproteins. The alpha-fetoprotein is basically a glycoprotein, which is comprising of 591 amino acids and 4% carbohydrate residue of 68 kilodelta proteins. So it is the main protein which is produced by the yolk cells and the livers during the early fetal development. Then it is decreased significantly by the age 1 and then should be only present as a low level in the adult. So the alpha-fetoprotein is a primary hepatic carcinoma patient. There shows an alpha-fetoprotein concentration is rise, especially around 70 to 95% of the PHC. So the elevated serum alpha-fetoprotein in the pregnant woman is also an early indicator for the spina bifida, encephaly, and polyembryony of the fetuses. And the decreased alpha-feto value reveals the possibility of Down syndromes for the fetus. So this alpha-feto marker has a clinical utilization as a tumor marker, not only in hepatic carcinoma, also for the neural tube disease and in the congenital disorder as well as in the pregnant woman. If we talk about more about changes in alpha-fetoprotein level 2 and 4, the changes in the alpha-feto levels due to 2 weeks after the initialization of oxalipatic-based chemotherapy is used to predict the treatment response and the survivals. And the major response for this purpose is that the difference in the survival time according to the status of the decline in alpha-fetoprotein levels is the hepatocellular carcinoma patient with the extrahepatic spreading, and those who have initial decline of alpha-feto have an oxaliplatic-based chemotherapy have that. So if we compare with the alpha-fetoprotein with the other commercially available analytes of competitors like Roche, we have a sandwich principle in both generation, the first generation and the second generation. So there's a one more question here. If you what do you have any idea what is the difference between this generation and like HIV third generation and HIV fourth generation? So do you have any idea for this, that we are using SNIDE alpha fetor AFP1, SNIDE AFP2? So do you have any idea? Or if you do not have an idea, I will explain you. Do you want some information about this generation? What is the reason for behind this generation, and what is the difference between this generation and the market available generation? Okay, let me explain you. So this generation belongs to the SNIDE. If the SNIDE has improved product in terms of in terms of calibration interval, in terms of sample type, in terms of linearity, in terms of any improvement in the product. They called them the previous reagent as the first generation, and the latest generation is the second generation. Maybe if they improve the calibration interval or sample type or a linearity or some other improvement in the kit, they can go for a third generation, right? This is the internal improvement of the SNIDE reagent is called a generation, which is specifically for the manufacturing side. But in the market, there is also a recommendation of third generation and the fourth generation. You know that in infectious disease, the third generation assays are those assays who has an highly specific and sensitive assays and have a detection of antigen or antibodies. But the HIV as of today is a fourth generation assay. That's why the HIV assay is called HIV combo. Okay. So the HIV combo assay, this is called HIV combo assay. So the HIV combo assay has a great sensitivity and specificity for HIV 1 and 2 and antibodies, along with the P24 antigen detection. So that's why they call them combo, and the combo means this reagent of fourth generation of HIV detects simultaneously the antigen and antibodies. And for the infectious diseases and the retroviruses, screening assays, the global goal is the early detection, or the detection during the seroconversion type is the big goal. So the early the detection, the early will be the prevention and the treatment of that disease. That's why they have jumped from the second generation to the fourth generation, while the HIV, HBsAg, and HCV are still third generation assay. In the future, maybe someone launch HCV fourth generation or HCV combo, means that can detect simultaneously the antigen and antibodies. And as of today, we have a TSH in a quantitative assay. We have a TSH which is called a third generation TSH. So if the sensitivity and the specificity and the linearity according to the global guidelines for the assay performance mean that's why the manufacturer claimed that their assay is a third generation assay. Okay, so this is the basic concept behind the generations of the assays. But in this AFP, that we have assays detection with the test principle of sandwich as compared to the Roche, which is the same sandwich principles. We have an improved calibration interval of 28 days in comparison with the Roche of just 7 days. We have a minimum sample volume along with the serum and plasma type, which is equally good to the competitors. We have an edge in the reagent test pack size, which is of 50 and 100. Along with that, we have a measuring range of from 0 to 1000, which is equally good as compared to the
competitors with the concept of limit of blank, limit of detection, and limit of quantitation. If we talk about an automatic dilution possibility for this assay, yes, we have an optional automatic dilution probability if they want to run a diluted samples for onboard, that we can be run this analyte with the onboard reagent diluent available with that reagent. So we have a free of cost 2 level of QC solution. With this 2 level of QC solution, you can run or verify the assay performance, and then you can report your patient results on the basis of free of cost QC compensation given by the SNIPE, while the other competitors, they need to have to purchase the separate calibrators and control to meet the quality guidelines according to the laboratory standards. Excuse me. So if we talk about the comparison with the alpha-fetoprotein available with the SNIPE meglumi alpha-feto, that's a regression value of 1.0 with the p-value of 0.001 on the basis of 27 clinical samples available, and that shows that we are equally good as compared to the other commercially available alpha-fetoprotein assay. If we talk about the brain tumors is basically an abnormal growth of cells inside the brains and the skulls. You can see that there are different parts of the brain, frontal lobe, then broca areas, and the cerebellum and cerebrums, and then brain streams, that's other malignant cells. So the tumors can grow from the brain tissues itself, either primary or the cancers, and the bit can be spread through the brain. That's called a metastasis. There are around 120 different types of brain tumors, and then common brain tumors which have include gliomas, astrocytomas, pilocytic astrocytomas, and they have a very vast range of that, including the lymphomas and epidermoids, and then including the pituitary adenomas and the epinolomas and the medulloblastomas. So these are the all 120 different types of brain tumors which are can be occurs in the brain tumors different classification. If we talk about the global prevalence of brain tumors, you can see here in the Americans region and the North and South American region, including the European countries, and then some countries of the Middle East has, and some African countries has an prevalence of greater than 5.3 people per 100,000 person. That's the global feedback for the World Health Organization. If we talk about the brain tumors, we have an S100 markers, which is basically a protein family of the low molecular weight protein found in the central nervous system glial cells. And this is a sensitive indicator for the CNS damage. If it's combined with the NSC, it gives you the international recognition for the hypoxic injury and prognosis in the cerebral ischemia. And this is very much important marker for the malignant melanoma and cerebral tumors. So if we compare with the brain tumor S100 and common central nervous system tumors, you can see that the different types of tumors like glioma, meningioma, and the metastasis, and then choroid plexus tumors, neurocytoma, all these synaptophylaxis and S100s gives you some clinical significance in some different brain tumors. So if we compare our S100 brain tumor with the Roche competitor in the market, that we have an improved calibration interval. You can see here we have a serum recommended, we have a PEC size, we have a LOB, LOD, and LOQ for that, and we have a where we have a broad linear range in terms of nanogram per ml, and we are providing free of cost quality control solution for those labs who wants to run with the patient with the serums, and there is no additional cost for the calibrated control. If we compare the commercially available S100 with the SNIDE Meglumi S100 using the clinical samples of 29 different values, the regression value is 0.96, which shows that our assay is equally good as compared to the other assays. If you talk about the different cancer types, we have a summary for that, like to rule out the lungs cancers. So these are the joint tumor markers can be used to detect, like ProGRP, TPA, CEA, CYFRA 21, 125, NSC, CA50, and CA19-9. If you want to rule out the breast markers, we have a very comprehensive menu which are available here. That's available from the SNIDE Meglumi platform, CA15-3, and then for the ovarian, pancreatic, liver, colorectal, esophagus, cervix, uterus, and brain tumors, all that type of carcinoma. The SNIDE as the only company which has a very comprehensive menu available from the Meglumi SNIDE platform. So we have a very comprehensive menu for the tumor markers and for the carcinoma markers, including the brain, pancreatic, liver, breast, and common, from the common to the rare parameters as well. Any question if you have? Otherwise, we have to start our last presentation. Okay, so I hope I have shared with you. I have shared with you the link, and I would like to again request you. I hope you will copy that link for the training feedback, right? And the second thing is, I have also shared your feedback. Okay. So I have also shared your feedback. In my opinion, that was a good idea if your customer who is doing screening, prenatal screening from the SNIDE Meglumi platform. So you can ask to your Chinese colleague to acquire that Preco software for the prenatal screening. And I also requested to my team leaders from the global support team for the training that as of today, they do not have any comparative of that Roma and then the Siemens prenatal screening software, apple to apple comparison. But as an customers or as an distributors and as an end users, you can install or send a request for the approval of that software on that customer side who are using more frequent sample for the prenatal screening, so that you can have and develop a habit for to using that software, and then you can learn more information about that prenatal pre-cow software for the prenatal screening. But as of today, we have not an exact feed comparison with the Siemens and then the Abbott. So no question. If let me start with the new presentation. The next presentation is about the Meglumi PSA and free PSA. PSA stands for the prostate specific antigen, and the free prostate specific antigen. It's basically a diagnostic tool for rule out a prostate carcinoma in male patients. So in this presentation, we have a 4-part. The first part about the background of the prostate specific antigen, and then introduction of PSA and the free PSA, and then clinical utilization of the prostate specific antigen versus pro PSA, and what are the solution from the Magluni platform the SNIBE has given for the PSA and the total PSA. So let's start the presentation with that in background. So background. So basically, the PSA is a small walnut-shaped gland in the males that produces the seminal fluid. So that's produce the seminal fluid that nourish and transport the sperms. So basically, the prostate cancer is that cancer of that specific prostate gland. It is one of the most common type of cancers in the men. It is not clear still as of today that what is the cause of that prostate cancer. So you can see here, this is the normal prostate. You can see if there's then some tumor in the prostate, that's called a cancerous prostate. So according to the WHO guideline for the carcinoma and the Globacon 2018 cancer observatory data of France, that the estimated age standardization incidence rate globally in 2008, both sexes, all ages, the breast cancers, the prostate cancers, and the lung cancers are the top 3 cancers in the world, and then followed by the other cancers. So if you talk about the epidemiological distribution of the prostate cancers, so among all the cancers, like you can see that the global distribution of the prostate cancers in the world, like in the North American region, and then the African region, and then this the Middle East region, which is more prone, and according to the region of the European countries, are more prone to that prostate cancers. But in other countries like India, China, they have more of a oral cavity carcinoma is more common because there is a typical the pan eating habits of there some materials that they may lead to the lipo-oral cavity carcinoma is more common. If we talk about the Russia, the more common carcinomas are the lungs related carcinomas. So if we talk about the symptoms of the prostate cancers, the tumors or the cancer cannot be felt by the doctors during the examination, and then can be felt because it has not spread outside the prostate, and then can spread outside, and then the troubling there, the urinating and decreased force in the streams of the urine, the blood in the semen, and discomfort in the pelvis area, and the bone pair and dysfunctions. So these are the symptoms of the prostate cancers, and on the basis of which they have a risk of the prostate cancers and that. Can you give me just 2 minutes, please, break? I'm coming in just 2 minutes. The risk of the prostate cancer, there are all races. I have an incidence of 104 cases. The mortality is 19.1, with as compared to the non-Hispanic white, with the non-Hispanic black, and among different people, there's a highest ratio of prostate cancers in a non-Hispanic black. Incidences are more, and even the mortality rate is more in the non-Hispanic blacks as compared to the other. The second number is non-Hispanic white people, and then they have a Hispanic, and the Latinos have a more incidence and the mortality per 100,000 people. So if we talk about uh, the age, about the from birth to 49, the probability of developing prostate cancer is 1 in 441 people. The age between 50 to 59, there's a 1 in 57. Between 60 to 69, 1 in 21. And between 70 to 79, it's 1 in 12. So birth to death is the ratio is 1 in 9 globally. The prevalence of the prostate cancers in male is expected, the probability of developing a prostate cancers. If we talk about the family history, if they have a family history, risk of prostate cancer is 8%. If the father or a brother have a risk factor, they have a 15%. If a father or brother younger than 60%, there's a 20% risk of prostate cancers, and the father and brother, they have 30%, and hereditary prostate cancers have a probability of 45%. If we talk about the risk factors, that the family history, the diet, the chemical, the hormones, aging, and the race are the most high risk factor for the prostate cancers among the epidemiological distribution in the world. So if we go for the screening of the prostate cancers, it is recommended for the men more than 50 years, including the DREs and the PSA test. There's a digital rectal examination that's called DRE. So the digital rectal examination helps to diagnose the prostate glands screening test along with the prostate specific antigen test, PSA. But there's a recommendation if they are going for a digital rectal examination, DRE, and the PSA test should be performed before that digital rectal examination, and there is a timeline after having a DRE. It is not recommended to immediately perform provide a blood sample for the PSA, because falsely elevated PSA results may be available, will be observed. So if we talk about the PSA and the free PSA, PSA stands for the prostate-specific antigen, and it's basically a glycoprotein enzymes which is secreted by the prostate glands. Most in the semen's, small amount released into the blood, and the PSA is present in a small quantity in the serum of the men with the healthy prostate, but it's often elevated in the presence of prostate cancer or other prostate disorders. It's basically a function of the PSA. What is the main function of that prostate specific antigen? It's basically liquefy the semens in the seminal coagulum, and it's allow sperms to swim freely, and it's allow the sperms into the uterus. So that's the major function of that PSA. So how it's work, that you can see that the prostate specific antigen, that's the types of that prostate specific antigen, that's the prostate gland, that's the prostate duct, which helps to release that during the ejaculation, that specific antigen into the bloodstream, and that bloodstream has a different types of PSA. And these PSAs are the free PSA, and that's the 20 to 30% in normal cases. But in the carcinoma cases, if the value of free PSA is less than 20%, so it may lead to the clinical diagnosis. Further confirmation is required for the PSA. If we talk about the, excuse me, that's an ACATA bound PSA, that's an anti-chromatyrepsin bound PSA, and the alpha macroglobulin bound PSA. So there is a one bounded PSA, which is called a total PSA, and then the free PSA. So the most PSA in the bloodstream is found in the serum protein types, and a small amount is the non-protein found, and it's called a free PSA. If the man with the prostate cancer, the ratio of free PSA to the 2 PSA is decreased, like as we discussed in this case of normal to the cancer cells. Any question? Okay. So what are the causes for the elevated PSA? Maybe some enlarged prostate gland, some prostatitis, means the inflammation or the injury of the prostate gland, or some prostate carcinoma condition they are raised. So if we go to the what cause an elevated PSAs, also a recent ejaculation and digital rectal examination and the bicycle riding are also one of the leading cause for the elevated PSA results. What are the clinical utilization of PSA and the free PSA? You know that the screening of for the prostate cancers men over 50 years helps to for the early detection, and the PSA levels between 4 to 10 are considered to be suspicious and considered should be given to the firming the normal PSA with a repeat test. And the risk stratification and staging is also very important. If the indications for the repeated elevated levels of PSA is there, then the prostate biopsy is performed to be obtained to a tissue sample from the histopathological analysis is recommended. And then the treatment monitoring, the PSA levels have a very clinical significance for utilization for the monitoring periodically after every 6 to 36 months for the treatment of the prostate cancers. More frequently, the patient with the high-risk disease, they have a less frequently in the with the patient with the low-risk disease if the surgical therapy of the radical prostatectomy is successful after removing the prostate tissue or a prostate cancer, then the PSA become undetectable within a few weeks, and they have subsequent rise in the PSA level in journal recorded evidence of the recurrence of prostate cancers after having a radical prostatectomy, or less commonly, it may be simple indicates a residual benign prostate tissue. So the early detection, according to the National Comprehensive Cancers Network, excuse me, they have a early detection evaluation. If the PSA value is less than 1 nanogram per ml and DRE normal, if not, then if the PSA is greater than 1.3, then the repeat testing for the 2 to 4 years interval is required. And after 1 to 4 years, if the PSA values is greater than 3 nanogram per ml, then see indication for the biopsy and periodicity that 3 is required. If the PSA values is greater than less than 4, DRE normal, if not, and no other indication for the biopsy, testing repeat is required at 1 to 4 years interval. If the PSA greater than 4 nanogram, very suspicious DRE, not a screen, that's the biopsy is recommended. So these are the baseline evaluation, risk assessment, and early detection evaluation on the basis of PSA and the suspicious DRE values for the early detection of the prostate cancers according to the guidelines. So the early detection with the DRE and the PSA, digital rectal examination, the prostate specific antigen, they have a mildly suspicious PSA normals, and they have a different DRE negative in case of the PSA, mildly abnormal between 4 to 10 microgram per liters, and the DRE mildly suspicious about the PSA, mildly active that. Then they have to go to the FNT PSA ratio. If the biopsy is normal, PSA normal or mildly elevated, and DRE only mildly suspicious, then the repeat DRE and PSA in a 6 month. So the transrectal ultrasound, or maybe a PSA density serum level driven by the transrectal ultrasound determine prostate volume, and the biopsy positive, then the treatment is required. So these are the guidelines according with the different prostate carcinoma. for that, for the cancer, for the BPH. Risk stratification and staging. So the men with the prostate cancers can be categorized into the low, intermediate, and high risk on the basis of their metastatic disease or the dying of the prostate cancers is one of the three variables, which is risk stratification, and then the National Comprehensive Cancer Network research stratification of the prostate cancers with low risk to intermediate and high to the high very risk. So that T stage, T1 and T2 stage, T2B and T2C and T3A and 4 stage, if the PSA value is less than 10, and the biopsy GS score is less than 60 GI, that should be considered as a very low risk or a low risk. And if the value of the PSA is between 10 to 20 nanogram per ml, and the biopsy GG is a 7, GG2 or 3, they have considered as an intermediate risk. For the high and very high risk, that's an 8 to 10 biopsy, and that's called the Gleason scores. If group grade is about 4 or 5, on the basis of the Gleason score is between 8 to 10, that's considered as high risk. So the treatment monitoring is also can be reviewed by this tumor prostate marker of the total PSA and the PSA with the positive digital rectal examination, and androgen depression therapy is required for that. If we talk about the SNIPE solution for the prostate cancer diagnosis, prognosis, and the risk stratification, is that we have two generation available, that the first generation total PSA and the second generation total PSA, which gives them a very informative information for that. So if we go to the generation, so the latest generation, we have a total PSA of based on the sandwich technique as compared to the competitors Roche, Beckman, Abbott, and Siemens. They all have a total PSA assay available from their platform, and they are using the same sandwich technique. The traceability or the accuracy is based on the standardization of our assay against 96 WHO over /670, which is equally good as compared to the other competitors available in the market. We have a second generation serum and plasma. Both sample type is recommended, which is equally good to the Roche as compared to the Beckman, Abbott, and Ellis Simmons. They have a limited serum sample type recommendation for that. Excuse me. So if we compare with the measuring range, we have a broad measuring range as compared to the other competitors, and they have a low measuring range up to 100 and 150 nanogram per ml. So for the prognosis purpose, where the physician require the exact value, we can give you the cost-effective solution from the SNIPE platform for the total PSA. With the minimal number of tests, we can give the accurate result up to the 400 nanogram. If they need a automatic dilution, that we have a probability of run that patient with the exact value having an automatic dilution if the results are exceeding more than 400 nanogram per ml. We have a clear concept of limit of blank, limit of detection and quantitation. On that basis, we have established our measuring range. The calibration frequency is comparatively better than the other competitors in the market, and we have an instability on the analyzer is 4 weeks, which is equally good as compared to the other competitors in the market. And we have a flexibility of 50 tests per pack size, which is much better than the other competitors in the market. Only the Beckman Access has an access of 50 tests. But the another challenge is the customer need to buy 100 test pack size, which is a bigger pack size as compared to the SNIPE, that we are giving just a pack size of 50, and the reagent kit also size of 50 tests. So if we compare the second generation total PSA of Snipe with the other competitors commercially available or using the clinical samples on the basis of different values, our regression value is 1.0 and the p-value is less than 0.001 on the basis of 23 samples. The conclusion for this evaluation is that we are equally good as compared to the other competitors available in the market, and the very excellent correlation with that competitors. So if we compare the free PSA assay for the testing of prostate carcinoma, that we have two generations kits, the first generation and second generation, as compared to the Roche and Abbott Alinity. They have a solution for that for the free PSA. We have a sandwich principle, which is equally good to the Abbott. The Roche is a competitive principle. We have a standardization against 96/668. We have a kit of 100 tests and 50 tests, while the other competitors have 100 tests or 500 tests, and the minimum 100 test pack size. We have a both serum and plasma sample type recommendation with the calibration frequency of 28 days, which is comparatively higher than the other competitors, Roche and Abbott. We have a measuring range of 0.02 to 50 nanogram per ml, which is equally good and better than the Abbott competitors. If we talk about the stability of the reagent, we have a 1 month onboard stability as compared to the 3 weeks and the 30 days of Abbott Alinity. If we talk about the limit of blank, limit of detection and quantitation, we have an improved and very comprehensive limit of blank in detection and quantitation, and it's in a much reliable according to the CLSI guidelines for the sensitivity and specificity of the each analyte. So if we talk about more in terms of method comparison, or when we compare our total free PSA with the second generation free PSA, this is the total, this is free PSA versus free PSA. So the free PSA second generation comparison with the commercially available second generation free PSA as this recommended, and then on the basis of 46 samples from range 0 to 50, that you can see that we have an excellent correlation of regression value of 1 with the p-value of 0.001, which shows that our assay of free PSA is equally good as compared to the other competitors available in the market. So that's an all about the today's presentation. If you have any question or if you have any comments, you can share with us, or if you have any query, you can ask me, so we can try to give you the answer right now. Otherwise, we can give you the answers a little bit later once you need it. Just give me 1 minute to, I have to make some pictures. So any question, if you have, you can ask. Okay, so please do not forget to send the feedback. Your feedback is valuable for us for the process improvement, and any suggestion if you have, you can give. And I hope I have give you the best is the information that I have in my mind, especially for the concept clearing for the limit of blank, limit of detection, and the limit of quantitation. Because usually, a couple of years back, the diagnostic IVD market was not well aware about the limit of blank, limit of detection, and quantitation. But right now, according to the sensitivity of CLSI 14-17-A guidelines, this is mandatory for the new assays launch, that they have to mention the limit of blank, limit of detection, and quantitation, along with the interference if they are using the competitors, they are using the reagent which is the containing the streptavidin. So if you if you have a competition with the tumor markers or inherited disease in terms of competition, real competition with the Roche, so you or SNIBE has a two big edge. So the first big edge is our assays are biotin free, so there is a no possibility of biotin streptavidin interferences in geriatric or treated sclerosis treated patient, because the high dose of biotin is given to those patients for the treatment of sclerosis. And then the patient who are generally, they are used to maintain their health, their beauty, the nails, hairs, and the skin beauty. The biotin is also a good supplemental, which is self-prescription basis. The people are using that medicine, or a multivitamin, which is containing a biotin, and the daily utilization is 30 microgram per deciliter is enough. But according to the global assays, which are prone to the biotin, if the patient serum contains the biotin, are those companies who are using the streptin. The Roche is using the streptavidin coated microparticle beads and the biotin-related antibodies and antigen in their assays. So the probability of cross reactivities, and then due to this, the false negative and false positive results, or a falsely depressed or elevated results, they may observe in their assays. So if you have any discrepancy with the competitors, you have to check the biotin interference or the other factors which play a very vital role. If you diagnose the right approach with the right approach, that there is some interference with the competitor assays, but the SNIBE is not using the streptavidin. We are using the ABI along with the ferrous oxide is a paramagnetic, super paramagnetic microparticles, which has a more binding side to give you the maximum yield. And then during the washing procedures, we have an outside the washing procedures, not in the measuring cells as compared to the Roche. They have a washing inside the measuring cells. That's why the probability of measuring cell contamination or the results reliability is compromised. But we have a washing mechanism outside the measuring chambers. So when we receive immune complex which is free of all unwanted materials, only the reaction will start with the starter 1 and starter 2 to emit the blue light of specific wavelength to detect the target analyte in the immune complex. So that's all about the today's presentation. If you do not have any question, or if you do not have any comments, so we can close today's presentation. Okay, so I hope you enjoyed these 2 days session, and let's have to finish that presentation. Thank you very much for joining us, and have a nice day. And if you have any inquiry, if you have any question, you can contact me directly through my Chinese colleague, or if you have any any some innovations or some idea, you can share with us. Thank you very much, and have a nice day. Take care and bye-bye.